Hi, everyone. This is just a quick little, sorry about that background. This is just a quick little lecture or video to give you an introduction to paediatric prescribing. I didn't write this content. I had some help from a specialist paediatric pharmacist friend of mine and another paediatric pharmacist that I've worked with at the Canberra Hospital. So basically, what we want to do here is just give you a bit of background. These slides are to provide a resource for basic concepts for paediatric prescribing, and you'll have an opportunity to talk about these principles and to have a practice prescribing in your paediatric prescribing workshop. So the learning outcomes, particularly with regard to this and also the paediatric prescribing opportunities that you'll get, is to really distinguish between common medication safety issues and apply them to paediatric prescribing. Use an appropriate height weight chart to calculate a dosing weight when you need to. Use a knowledge of medicines and medication safety in paediatrics to provide counselling on medications to parents and paediatric patients. And also to talk about both advantages and disadvantages of common prescribing references when you're considering prescribing for paediatrics. So here's some just very important general concepts. Children are not small adults. They are very different. Their bodies are different. Their pharmacokinetic processes are different. So they can't be treated you can't just give sort of a half an adult dose to a pediatric patient. And then on that same vein, babies are not just small children. So again, it's not just about making a smaller dose for a smaller person. Their pharmacokinetics are different, which we'll talk a little bit about. So children are much more likely to have a medication misadventure compared to adults when they're inpatients. And there's the problem for us is that there's not a lot of research in the pediatric population, just in general. And so a lot of medications that are used are actually off license. So it means the drug company hasn't actually applied to have them approved by the Therapeutic Goods Administration to be used in pediatric patients. So it can be as much as 90% of medicines that we use in the hospital. So only about 30 to 40% of medicines in Australia are actually licensed for pediatric use. There's a lack of available dose forms. So not everything comes in a child-friendly dose form. So you can't get a liquid version of everything. So there's some complexities around dosing, particularly when it comes to dose forms that aren't marketed for children, and also administration difficulties. Children have a reduced ability to tolerate and also to tell us if they're experiencing side effects. There are different pharmacokinetic parameters, which we talked about, and lots of calculations when it comes to dosing medicines in children. So it's really important that we're practical, both with dosing and dose forms, but also with the timing of our doses. And then on discharge, you need to be able to think about what would it be like if you had to give this medicine to a child when you got home. So is the written information that we're providing relevant to children? So a lot of medication information that we hand out on discharge to patients isn't necessarily for children. So in terms of dosing medicines for children, most of the time we dose in a milligram per kilogram way. Sometimes we use body surface area, and we'll talk about that in a moment. The doses are always capped at the adult dose. So even if the child in a milligram per kilogram way if you calculate a dose that's bigger than what we would give an adult, we would never give more than what we would give an adult. And we need to think about how to identify and then also how to dose children that are obese. All right, so what weight do we use? So how do you know what a normal dose weight is for a 5-year-old patient? You need to have a decent understanding about what is a normal weight for age. And there are these wonderful percentile charts available which tell you what percentage of children are what weight at what age. Body surface area, we don't commonly use in general in terms of medicines anymore. Most commonly it's used for chemotherapy prescribing, but the calculations there, it's basically the square root of the height and weight multiplied together and then divide the whole thing by 3,600. But you probably won't have to do that particularly much. And nowadays you can get lots of apps that help you calculate body surface area. So generally, when we're talking about dose weight, we will dose on the total body weight, the weight of the child. And remember, that means that you still never dose above what an adult would get for that medication. And again, you have to think about the normal weight range for the child's age. And then if the child is significantly more than what you would expect for that age, then you need to dose by ideal body weight for some medications. So to calculate an ideal body weight, again, there are lots of apps that can help you do this, but the way that we recommend to do it is you get the percentile charts. And so if you know the height of that patient and their age, then you can look at the dose chart. I'll show you how to do this in a moment, and work out what the usual weight for a child that age and height is, and then you dose based on that weight. So that's their ideal weight for their height and for their age. So let's have a look at that here. So here's a height. This is a height chart over here. So we've got a 6-year-old child who's 115 centimeters, and on the scales today weighs 30 kilos. And so what we do is we get a height chart and we say, okay, we've got a 6-year-old who's 115 centimeters. And so we draw our line up at the 6-year-old up until 115 centimeters. And we can see here that for her, and I know it's a her because I've got a pink chart, so there's both boys and girl charts. So I can see here that this child is, for her height, is in the 50th percentile. So perfect. Right in the middle, right smack bang in the middle. And then I go to a weight chart and I go to the 50th percentile. And I follow the 50th percentile down till I find 6-year-old, or conversely, I go to the 6-year-old age and I go up and I find the 50th percentile because that's what she was for height. And then I follow that across, and you can see here that her ideal body weight is 20 kilos, whereas up here, her actual body weight, she's on the 97th percentile. If her height was up on the 75th percentile, then we would go here, we would go 6-year-old on the 75th percentile, and we would dose based on that. So we match her percentile for height with her percentile for weight, and we dose on that is then the dosing weight. Hope that makes sense, and you'll have an opportunity to practice some of that. So how to choose a drug and a dose. So not all drugs have evidence or safety information in children. You always need to use a reputable resource when you're looking at paediatric medicines and dosing. And the gold standard in Australia is the Children's Australian Medicines Handbook, AMH, online. You look for that. This is where you'll find paediatric specific monitoring, adverse effects, etc. Ask for help and just prescribe safely. Be sure to follow the recommendations. So why does it matter? Well, children grow and develop, and as they grow and develop, their pharmacokinetics change. So ADME, absorption, distribution, metabolism and excretion. And we know that if we use a weight-based dosing, that's the best method. That is the best method to account for these changes in children. And so absorption, just to give you some examples, gastric pH is high in neonates and it declines as the child gets older. Intestinal motility changes and matures throughout infancy. They've got a thinner stratum corneum, which means they have increased absorption across topical patches and creams, etc. And they have an increased ratio of body surface area to mass. Distribution, they have a higher proportion of extracellular fluid as they're little tiny babies and a higher percentage of total body water. And there are also changes to circulating plasma proteins, which in turn affects binding of highly protein-bound drugs. And the body fat percentage increases throughout their childhood. CYP enzymes become more active sort of from when you're born for the first 3 months of life. And then around 2 years of age, children have the same or very similar CYP activity to adults. And we're not super sure what happens to phase 2 metabolism. So CYP enzymes, of course, are phase 1, but we're not super sure how the phase 2 enzymes really change as children develop. Excretion via the bile requires functioning gut and enzymes. And again, as we've talked about, that changes over time. And excretion via the kidneys increases through infancy, and around a 1-year-old has a similar kidney rate of renal excretion as adults. Now, paracetamol, it's just really important to talk about specifically because paracetamol is the most commonly prescribed drug for children, but that there is a higher risk of toxicity in children than there is in adults. Now, the usual dose for children is 15 milligram per kilogram, dosed 4 times a day. And they can't metabolize paracetamol as well as adults. They have an increased risk of toxicity. So when you're dosing pediatrics with paracetamol, you do need to use an ideal body weight. And that's actually really important because it's one of the most commonly prescribed drugs. So we do need to change the calculation. If they're on extremes of weight for their age, then we do need to change to that ideal body weight that we went through just before. Now, remember, when it comes to children, giving them medicines, we have to think about how they're going to take them. So they need to be able to take them. They need to be tasty. If a child doesn't like the taste, they won't take it. They don't care that it makes them better. They're just not going to. Unfortunately, it really, really matters. So we need it to be palatable. We need them to actually take it. We need to be able to measure it safely. So we need to be able to measure it accurately. So if you do a calculation down to the 3rd decimal place, you need to think, how is somebody actually going to measure this volume of liquid for this safely? It needs to be practical. And you can find information both in the children's AMH about this, so it'll give you some information if your dose form. So if you're giving, let's say clindamycin is an example, an antibiotic, it doesn't come in a liquid, it only comes in capsules. And so you can find information about dissolving the capsule in water and giving a part, dissolving a 150 milligram capsule in 10 mils and giving part of that volume to a child. But you can find that information both in the children's AMH, which is the gold standard that we talked about, but also in MIMS has got a little tab that gives you information. It's called Don't Rush to Crush, and it gives you information about crushing tablets and dissolving things, not just for children, also for people who can't have a full dose tablet, say somebody with a nasogastric tube, for example. So you can find information there too. All right, so let's work through an example. So we've got Daisy. She's 6 years old. She weighs 30.3 kilos and she's 115 centimeters. And she's dosed for paracetamol, 450 milligrams every 6 hours. So if we calculate that out, 450 milligrams is approximately 15 milligram per kilogram if we dosed on 30 kilograms. Now, we want to have a look and see if 30 kilograms is a usual weight for a 6-year-old child. So we go, of course, to the height chart, and we know that Daisy's 115 centimeters and she's 6 years old. And so we draw our lines, we get our dot on our percentage line. And you can see here, she's in the 50th centile. So then we go to our weight chart and we go to our 6-year-old and we go up to our 50th centile, and we see here that her dosing weight would actually be 20 kilos. So she is 30 being dosed on 30. So she needs a dose adjustment. So we need to recognize that we shouldn't use her total body weight. So her total body weight is 30 kilos. Her ideal body weight is 20 kilos, and the difference is more than 20%. So it is worth changing the dose. Bigger than what is usual. And so the new prescription should be for paracetamol 300 milligrams every 6 hours or 4 times a day, dosed at 20 per kilo. So 15 milligram per kilogram based on a 20 kilogram child. So counselling about medicines with children is really important. There was this phenomenal study long time ago now, but basically showed the importance of appropriate counselling. So they said some patients were going to get their prescription and some verbal instructions, and around 37, less than 40% of those people who went home then dosed that drug correctly. Group 2 got the prescription got a syringe, and they got shown how to draw up the dose in the syringe. And about 83% of them got the correct dose when they got home. The third group got the prescription, got a syringe, and on that syringe had a line marked where they should draw the drug up to, and 100% of them got the dose right. So it just really matters. Education decreases errors. So kids, it's important to include them in your counselling. Less than 2-year-olds, children younger than 2, they can't learn about medicines. I mean, they're too little. But between 2 and 7, you can talk really simply about medications. Once they've reached 7, you can really start just involving them in what's going on, talking about dose forms that they might like, and making them more engaged in the process. And then once they're 12, you can talk to them like they're an adult, and you should really involve the child in the discussions as much as you possibly can. Kids are concerned about taste. Don't lie to them. Don't say it's going to taste delicious if it's not. But also we need to think about giving advice about how to make it more manageable to actually take these maybe not so palatable medications. So things like blocking your nose when you swallow, using chocolate topping, strawberry Nesquik, apple puree and yogurt are all really sort of common ways that we can mask the taste of medicines for children. All right, so what are the sort of take-home points? We usually calculate pediatric doses using milligram per kilogram. We need to make sure that there's an appropriate dose form, or if there's not, that we are able to provide information so that that drug can be given safely and appropriately. And we need to make sure that we can actually measure the dose. So there's no point prescribing something to the 3rd decimal place if that's not going to be manageable for the either the nurses or the parents to actually administer to the child. Okay, so thank you very much. And I can't wait to spend some more time doing some pediatric prescribing with you in your workshops. Thanks, ta-da.